So welcome everybody in this 9th-month progress report under unusual conditions. My name is Panagiotis Paraskevopoulos. I come from Greece and I work together with Balin and Mahmoud, which have been great, and I should definitely thank them for their cooperation. There are a few things that have changed about my topics. One of them is the new title in my first project, which is now the addition of antegrade stenting in patients undergoing hepaticogastrostomy for malignant biliary obstruction offers better outcomes. And my second project, unfortunately, because I didn't get the support that I expected, we had to drop the variceal bleeding prediction model, and we are going to check about the efficacy of different ultrasound-guided biliary drainage techniques. So, a small reminder for my first project: the prevalence of malignant obstruction is approximately 15 to 100,000 people, and for many years now, ERCP has been the gold standard. But over the last few years, this has changed. Percutaneous biliary drainage is usually the procedure of choice in case of failure of ERCP, but over the last decade and a half, ultrasound-guided biliary drainage has emerged as an alternative option. And compared in a systematic review and meta-analysis, comparing percutaneous biliary drainage and ultrasound-guided biliary drainage, it appears that ultrasound-guided biliary drainage offers better outcomes. And in the literature, although it is used extensively, there is not a lot of comparison between the different techniques. There has been some comparison between choledochoduodenostomy and hepaticogastrostomy, but not so much about what we are trying to do. So what we're trying to do basically is that we want to see if the addition of antegrade stenting during the hepaticogastrostomy procedure is something that is actually a benefit to the patient, because it has been hypothesized that it offers a better, lower adverse events profile. Also, the addition of the hepaticogastrostomy acts as a route in which we can go and place the antegrade stent. So when we go out, we don't need to have bile leakage, so it minimizes bile leakage. So basically, this is what we're trying to do. We, in the beginning, the project started as a direct comparison, but eventually we moved on to indirect comparison, and basically we are doing a proportional meta-analysis. So as you can see here, of course, if you do not have access to the common bile duct, or in case of surgically altered anatomy, usually the endoscopists that are specializing in ultrasound-guided biliary drainage, what they will choose is either hepaticogastrostomy or antegrade stenting. So if I recall correctly, I think it was Imai in 2004 that was the first one that compared these two techniques, so the combination of these techniques. We have updated our search key in the 16th of June. We have finished with 25 eligible articles. This is the risk of bias for the direct comparison. There is another tool that we use for the indirect comparison. And now, with great pleasure, I want to show you our outcomes, because they are not only clinically significant, but we have reached statistical significance. So for the technical success, as one can imagine, basically what we're dealing with is two procedures in one versus one procedure. Of course, just the one procedure, just hepaticogastrostomy, has a higher technical success than the combination of hepaticogastrostomy and antegrade stenting. This is something reasonable and something that we have to take in mind, because since it is easier to perform this one procedure instead of the combination of procedures, the rest of our outcomes, the profile of the clinical success and the overall adverse events needs to be better, so we can actually use this procedure. So indeed, it appears that if only so slightly, clinical success is more common during the combination of hepaticogastrostomy and antegrade stenting, 0.94 to 0.88, statistically significant. The reason is basically how we measure clinical success is a decrease in bilirubin. Most studies have a cutoff of 50%, but there are some that have 60 or even 70%. So we can safely say that in a cutoff of 50%, we can be sure that the combination of the procedures will be more beneficial. This of course makes sense because the bile can drain into two different locations. For the reintervention rate, we have kept it a direct comparison because we didn't have enough data. We have not reached statistical significance, and it appears that it is quite similar between the two interventions, although of course the confidence interval is high due to the low number of patients. Finally, for the overall adverse events, it appears that the combination of these two procedures of hepaticogastrostomy with antegrade stenting versus just hepaticogastrostomy appears to be significantly better in the overall adverse events profile. It cuts it almost in half, or if you look at even the confidence interval, it's approximately half at best case scenario that you get, and worst case scenario is like equal. But it is very, very good results. They are statistically significant. It appears that it's not only the bile leakage, but also the bleeding that is minimized. Unfortunately, we could not do subgroup analysis to confirm these results, but that's it. And this is the progress of our manuscript. I have recently received the last outcomes, and I just need to write the discussion. And we're planning to try our luck in these journals. I have finished the grade, and this is where we are. For the background of the second project, it is very similar with the first project. Again, we are going to deal with the various ultrasound-guided biliary drainage techniques. There are two different approaches. We will probably combine them into one manuscript after some discussion with my supervisor and SMS. One thing we want to look is the exposure of the different stents, the plastic, the metallics, and the lamps, in terms of clinical, technical success, adverse events, and maybe time to stent dysfunction, if we have enough data. And the other thing we would like to do is basically compare all of the different ultrasound-guided biliary drainage techniques, choledochoduodenostomy, hepaticogastrostomy, antegrade stenting, the combination as we did in our first project, and if we have enough data also for the Rendezvous technique. So overall, this is my progress. I am very happy, especially about the first project, because it was something that I discovered accidentally almost, and I mean after a lot of search, and I was really positive that we're going to actually end up having good results about it. And in the beginning, when we did the direct comparison, we didn't have statistically significant results, but when we did the indirect comparison, the results were statistically significant, they are clinically relevant, and I'm very, very happy about the project. So, thank you very, very much for your attention.